Thank you so much, Kate. So we now have the honor of, and I guess I have the clicker here so we can get the next slide. So Karen Hill has many letters after her name: Ph.D., MSN, ANP, PhN, and indeed, we are so honored to have you, Karen. And I'm remembering our first phone call where Karen shared that she had started in our medical system as a 16-year-old medical clerk in a nursing home, is that right? And she worked her way up to be the amazing human being that she is today. And I think we're especially lucky because Karen brings to us such a wealth of experience in different healthcare settings. And I think her presentation is going to be extremely informative. The thing that struck, we did this in Merced yesterday for the Central California Alliance for Health folks in Merced. And I don't know how many of you know Glide Church in San Francisco. How many of you know Glide? Awesome. So Karen worked with Glide Health Services to create a chronic pain program. And her work is trauma-informed. And we've heard a lot of us this concept of trauma-informed care. And indeed, it's a vast area that's just mushrooming. And the intersection between mindfulness and trauma-informed care is extremely interesting and important for us to all really deeply take in. And with Karen's 26 years of experience in administrative work and direct clinical care, we're in for a treat. Her bio will be on the website as well, so I'm not going to give you all the amazing facts and figures, just to say thank you, Karen, for joining us today.
Thank you.
Thank you.
I'll have this here. Oh, okay. Okay, great. Well, this is, I feel like I'm at home, since folks know where I'm from. It's such an honor to be in front of you today. I love clinicians. I love this work. Done it a long time. I didn't set out to get here to work with underserved populations. I tell this story, I didn't tell it yesterday, but I tell this story when I was offered the position at Glide Health Services, to come as a new nurse practitioner, I had never actually heard of a community health clinic. My whole life had been inside the hospital. Folks had come into my house at UCSF, major abdominal surgery, liver transplant, big head and neck surgeries, big GYN surgeries, all of that stuff. And when I was offered to come into community, and I was on my way to the interview, and I saw people lying on the streets and doing all sorts of things that I didn't think people did in public, I said, Lord have mercy, I like to dress up. What in the world am I doing here? But you know, I'm going to ask you today to be open, because the universe can teach us all kinds of things. And because I was open, it actually turned out to be one of the best jobs I've ever had in my life. And when I left there 2 years ago, I retired from the university after 33 years of service. I am going to commit the rest of my life to working in safety net. So I currently now work for a place called Health Management Associates. And it's a consulting firm, and we consult in big safety net organizations all across the country. Before I start talking, I want us to take a few deep breaths. So I want to bring you here. I want you to center. I want you to open up. So if we could just do 3 breaths. Big ones through your nose and out through your mouth. 1, 2, 3. I should hear you. Your belly should expand. And see, we've dampened down our stress already. This is who I am. My niece on the end, Talia. my two grandbabies who live in Austria, and then just my rock and the guy who makes it happen, my husband. So what I'm hoping that we do today is I'm just going to define trauma-informed systems of care. What does it look like? How do we define it? What does that mean? And how does it apply to chronic pain? My colleague, where is she? She's probably in the restroom. Yeah, she's actually really great because, do I need to walk around with this?
Yeah, there's one there if you want to walk.
Okay. I have to walk, so sometimes I do this. But she said something that was really interesting, and I wrote it down because she says that, on this side, that the nociceptors signal danger for our bodies and our brain. But you know that same thing happens with our emotions, right? And so things can happen in our lives that signal danger for us and then actually turn into pain and are hurtful for us. Relate some guiding principles and practical tools. An interprofessional approach, it is essential. It's essential if you're not doing that now. We need to change the script on that. Explain some strategies for how to support the healthcare team. This work is hard. It's hard, and it can get really messy. And so we need to take care of ourselves while we're taking care of patients. And then just some key considerations for a chronic pain program: evaluation, sustainability. I think I see two things sometimes happening as I talk to people about this around the country, is that we have chronic pain programs and protocols, and then we have practitioners who are providing chronic pain service to patients individually. And in order to do this work comprehensively, you really need to have the context of safety. And safety means that there's structure, there's rules, there's protocols, and there's compassion. And so someone asked the question about, I think it's this young woman in the back, asked the question about how do you talk to your patients about substances? You talk to them openly, and you talk to them straightforward, and you talk to them within the context of safety. So I'm reading Toni Morrison's book now, and it's called God Save the Child. And there's a line in there that says, the sufferings of childhood can shape and misshape the life of an adult. Truer words were never spoken. That's my baby. So this term of trauma, what are we talking about? Do you mean hit by a truck? Yeah. Do you mean the shootout that I was at the beauty shop? Yeah, I was at the beauty shop, and there was a shooting that went on while I was there, and I told the story last night, and my fight or flight kicked in, both things kicked in, and I was traumatized by that. And so it took me about 1.5 years to actually drive on that street again. And I still, to this very day, when I walk into a beauty shop, I know where the exit is. So those are all things that stick with us. But SAMHSA tells us individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. That's the context for what we're talking about today. So I also hear this term, well, what do you mean? Where are you? Trauma's on a spectrum. There's all kinds of trauma. So our folks here, oh, here it is, I'm pointing in the wrong place. So we have historical trauma. What does that mean? The Holocaust, the Sudan, the Khmer Rouge, what's happening right now, slavery, all of that's historical. Insidious trauma, insidious compassion fatigue, we all can experience that. Vicarious trauma, you hear the stories, people live in community, all kind of stuff is going down in community. They're not involved, but there's this sense of danger all around. You know, my 18 to 30-year-olds said to me, nurse, they call me nurse, I'm not afraid of getting hurt on the job. I'm afraid of getting to the job, that I'm gonna get shot on the way to the job. Secondary trauma, we're going to start like right down here, and we're going to move into this context of toxic stress, but you should know that all of this affects pain and how we view things. How many folks here know about this study, the Adverse Childhood Experiences Study? Good. So Vincent Folletti and I know each other quite well. And he's an interesting guy who set out to look at, in a general population, he sort of stumbled on this work, a general population, the trauma, how trauma was linked to health outcomes. And so he looked at a population of Kaiser patients and found that those with higher A scores actually had more health effects from all causes across the spectrum. So what do we mean when we say that? So there's more divorce, there's more suicide, there's more self-harm, there's more drinking, there's more substance abuse, there's more job loss, there's more diabetes, there's more Hep C, there's more suicide, there's more of all of it, including pain. Now, the thing that was interesting to, oh, wait a minute, come on now, is that they were mostly white. This is what was important about this. Mostly white, college educated, 30 years old and older, right? Because we all sort of, there's a narrative that all of this adversity only happens to poor folks. It only happens to people of color. It's not us, it's them. Right? Okay. Well, he dispelled that myth, and people started taking notice. What he found is this. Look at this, is amazing to me. 28% of those folks reported sexual abuse. 26.9% household abuse, substance abuse, mental illness, divorce, 10 indicators which increase their risk. The other thing that's interesting, and people don't hear this much, is when he first reported this work, at a big meeting, 500 of his medical colleagues, they nearly booed him off the stage. They said, you know, you're crazy. What happened to you from 0 to 18 doesn't matter in your life. What are you talking about? You don't know what you're talking about. And the way this study got funded is there was somebody, an epidemiologist, Robert Anda, he was also in the audience, and he said, you need a big cohort, which you have with Kaiser, and you need some money, which I have with the CDC, and hence we have the ACEs study, which is now, I think it's 20 some odd year. ACEs are common, we now know. 2 out of 3 folks in the study had at least one. If you had one, that was about 50% of those folks actually went on to have 3 if you had one. That women were more likely to have scores greater than 5, and we found out that the reason that is there's the sexual abuse risk for women. And that we also know that it has adverse effects on our stress systems. I worked with, I was the VP of programs for a small community clinic in San Francisco called the Youth Wellness Center. If any of you know Dr. Nadine Burke, she's a pediatrician. She's one of the first in the country, is starting to build a program around screening and doing treatment for families with trauma in the Bayview Hunters Point. And what Nadine says is that stress and trauma gets in our skin, it gets in our DNA, it changes our brains and how we process. So people want to know who's at risk, and what we now know is that at least in the ACEs study, 12.5% had 4 or more. In the CDC, the breakfast study that looks at folks across the continuum in the United States, it's a survey, telephone, the answer, it's about 14% have 4 or more. We also know that 4 or more is when you start increasing your risk, right? Look, all of us have something. All of us got a little something. We don't just get out of this life without something happening. But many of us have the support of a supportive adult to help us through the process. How did I get over that traumatic event at the beauty shop? Because you know, we all have to go to the beauty shop. And I had to get back to the beauty shop. Is my husband was like, look, let's just drive over there. Let's drive over. We don't have to stop. We're not going to stop. We're just going to drive by down the street. Okay, we're just going to drive down the street. Because I wouldn't even go over there, right? I was tripped out and go over there. So that's how, and we talked about it, and I called all my friends, and I talked to them about it, and they supported me through the process. So I was interested in my work, Vincent looked at a 30 and above mostly. I think 5% of those 20,000, 17,000 were in my age group that I was interested in. But I wanted to know in an urban community health clinic, Glide Health Services, what did the trauma look like? Because I was taking care of these young people and this kept coming up. And what we found in a small study with 134 young folks is that there was a mean score of 3.8. Their ACE scores were 3.8. That the 26 to 30-year-olds reported an average of about 4. The females were inconsistently higher, right? And then kids who reported, or young people who reported, emerging adults who reported that they were multiracial had actually 4.8. This to me was striking. 18 to 30, that was the criteria to get into this study, and 43% of them reported mental health issues. 31% of them reported that they had pain issues. So see, this stuff starts real early. Work injury, they were getting hurt on the job. They had health problems in a population of young folks that you would think would be ordinarily pretty healthy. So some of you in this room answered anonymously and gave us a cumulative score of what the ACEs were, because I wanted to bring it home so we could talk to folks about this. And in this group of the 61 folks who gave us a cumulative score, 16% had 4 or more. 27% had 3 or more. So this is right here at home, and this is one of the reasons why TIC, trauma-informed care, is so important, because it's not just them, it's us. The things that trigger them may be triggering us, right? And so it's important for us to have a framework, a way of thinking about this as we deliver this care, of how we talk to ourselves. And what we're going to see in a minute here, who's at risk, at greater risk, are these folks. You know, are folks that are unborn. How in the world are you born with ACEs? Well, I just looked at 10 charts from 25 jails. It was about 25 jails. We were looking at a system in Albany, and I was screening these charts of inmates who were pregnant when they came in. So here's the mom with Hep C, here's the mom who's been raped, here's the mom who's the sex worker, the mom who uses heroin, the mom who drinks alcohol. We come out of the womb, these babies come out of the womb with ACEs, right? And then we have our elderly, we have our LGBT folks, our ethnic, all of these people institutionalized and jailed. You know, some of the reason you're jailed is because you got the ACEs, right? So to bring it home again, how does this ACEs and trauma and all of this work? Well, you have, and we were going to show you a video, and we've got some technology problems about the neuro, the HP axis, our adrenals kick in and all of that, and it's going to be on the website. But essentially, you have a stressor. I'm going into the beauty shop. Something happens. What do? I say, duck down, run. Which way am I going to go? I told the story last night. I said, well, I don't want a bullet in my head. I don't want one in my back. If I have to get one, this rump can take it, so drop low. And that's what I did. And then I got behind a trash can and I was like, okay, because I'm hearing pow, 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 pow. What are you going to do? I said, you're going to fight. That's what you're going to do. I had the trash can. I was like ready. He might kill me, but I'm going to go down fighting. So that kicked in. And then when relief or support is given, the stress returns to normal. I get to my car. I found my glasses. I'm driving home. I tell my husband, get the martini ready. Let me tell you what went down in the beauty shop, right? Okay. And then what happens in constant stress, folks who are living with profound deprivation, you're worried about hunger, there's fighting in the house, there's sexual abuse of the house, mom or dad is getting beat up, all of this stuff, is that your adrenals in hyper mode all the time. You never calm down. There is no safe adult. So they stay this way, and that cortisol, that fight or flight, then starts turning on the body, is what really happens here for us. Well, come on. We're stuck. That's funny. Okay. Yeah, here we go. I think it's going to work now. Thank you. No, it's not. Click. So the thing that happens is our bodies are protecting us. You have a stressor. If you were to see this next, I want to show you. Is it going to go?
Okay, we're picking it up.
Okay. If you were to see a tiger or a lion, what will you do? Tiger or a lion approaches you all the time. What are you going to do?
I'm going to run away.
Right. Oh, well, do we have to start from the beginning? You're going to run away. And you're going to get away, and you're going to talk to people and say, oh my God, I was walking down Main Street and I saw this tiger and I got the heck out of there, whatever. But for some folks who have toxic stress, for some folks who have these kinds of problems, the tiger never goes away. The tiger is always there, right? What we now know about trauma and the effects of adverse childhood experiences is that they're intergenerational, they're epigenetic, and they actually lead to early death, right? So we have this trauma. Are we here? I want to show you my picture. Okay, all right. So there's a model, and it's the Robert Anda model, and on the bottom is ACEs, and then it talks about how it changes our neurodevelopment. So when your body, when our developing brains from 0 to 18 are developing, this constant cortisol, this hyper-vigilant state that babies and children and folks are actually exposed to, it changes our neural development. The neurons in our brain don't develop the same way. The connections change. And so the reason that I think that trauma-informed systems of care, the reason that all of the stuff that we're learning about neurobiology is so hopeful to me is because it empowers patients to say and understand that you really do have a lot of change. You can change the script. You can help to calm down your neurosystems with things that Kate talked about, some things with education, some very practical tools of how to calm ourselves down, to talk our way through a thing. And this is what some of the mechanisms that we use for people to understand. When I talk to my patients about how trauma can affect their lives, they're like, thank you so much for helping me to explain. We got it? Oh, okay, let's get there. Talked about this. Learning and reasoning and neural connections in the brain are weaker, right? We now know that meditation and yoga, all of those things help those synapses and those connections to reconnect and to strengthen. There's literature around this. But here's my friend, the tiger. See, he's here all the time. He's making me afraid right now, right? And so often when patients come into healthcare systems, and when we they come into things that they perceive are dangerous, right away they start thinking that they have to protect themselves. Here's our pyramid I talked about, intertransgenerational and epigenetic mechanisms that actually lead to early death. So let's get some dialogue. We talked about trauma, we now know what that is. What do we mean about chronic pain? An unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in such terms. So it's subjective and personal, informed by culture and life experience. See, that's the key thing. Culture and life experience. People experience stuff different, right? In some families, somebody you walk up and they slap you inside the back of the head, that's a signature that I love you. Another family will be, wow, that's abuse. It's culture. It's how we talk to each other. This is how we do it, right? Learned by the application of the word in early life. Your baby, somebody falls down. Oh, boo-boo, you hurt yourself. You know, kids will look to you to see, should I be crying now, or is this an okay thing? Okay, let's see if this is going to work. I wanted you to hear what our patients, how they describe it.
Sometimes it's really frustrating.
It's when I scared I'm hurting them, every naked illness.
Miserable experience. It's like barbed wire in your leg. It's just ridiculous and painful. Just miserable.
With this pain for 7, 8 years.
A little over 5 years.
Probably about 10 years.
Probably been about 15 years.
I just wanted to hear it. You know, we can do all of this stuff by looking at the literature and saying what pain is, but the most important thing is to hear how patients perceive their pain, to hear them describe to you what their pain is, what their experience is. So our patients, when we had our chronic pain program at Glide Health Services, if you were going to be prescribed opiates for non-malignant pain, there were certain things you had to do, and part of it is that you had to look at this video, you had to agree to a chronic pain program, you had to pick a menu of things that you were going to do to promote self-efficacy. We did it as a team. So everybody knew who was being enrolled in the chronic pain program. So how big is this problem? How many of us are hurting, right? 116 million, 1 in 3 adults reports pain. Worldwide, it's 1.5 billion. And we do know that it's significant. Look at the cost of this. This is the cost, $635 billion, right? When we talk about job loss, family loss, the cost of social services, health care loss, all of these medications, this is something we've got to deal with in this country. Not to mention the abuse and the deaths, right? So I wanted to make the link. Fibromyalgia and somatic pain disorders. I can't pronounce those names, but we started talking about this way back in 2002. Arno reports that depression, chronic pain, diffuse physical pain, pelvic pain that we can't really we can't find a really cause and reason for, often is linked to sexual abuse in women, right? Kopek says that increased self-reports of arthritis. In the Hypothesis Journal, people just writing about things that they're thinking about. Bartholomew suggests that all of this psychophysiological activity that we see should maybe lead us to start looking at early trauma. What we're thinking about doing now is looking at the trauma first, sort of screening for that maybe universally, educating universally, but he says that maybe the day is going to come where you have this complex that should make you think of this. Think of your patients that you're like, why, we're doing all this stuff right. Why are they not progressing? Why do they progress a little bit and then they go back? How many patients have you had in front of you that were homeless or their diabetes was out of control, their hypertension was out of control, all of these things were out of control, and you finally get them on the train moving the right way, and then you see them in 3 months. It's all back to square one, right? This should lead us to investigate. Gooseby says ACEs, depression, and chronic pain, and poor people, yeah. Chevelle talks to us about the shortening of telomeres, right? This early aging of our bodies, this weathering that sort of happens. Look at this here. Baumeister reported elevated C-reactive protein, interleukin-6, tumor necrosis factor, pro-inflammatory states. So that's why we see more cancer, all of this inflammation in the body with folks who also reported high ACEs. The bridge and the link is clearly developing now. Folks with IBS, this study here was linking IBS and GI distress with women who'd had sexual abuse. So, okay, we know that it's linked. We know trauma and ACEs go together. Let's just get some assumptions before we talk about this thing. This has to be patient-centered. It's a whole person approach. It's so interesting to me that we have separated the mind, the body. We don't think of that. You don't get into your car without any wheels on it and no seat and no engine, right? So we're talking about whole person care. We're talking about context and community. And I know that you're tired. You're like, oh my God, is she telling me we've got to do something else now? Meaningful use, patient-centered care, transformational this, teamwork. Yeah, because trauma-informed care is going to help get us there, right? Healthcare delivery can be traumatizing depending on your context. Everybody, the providers and the patients, want safety. They want to feel valued. They want to feel like their words mean something. We also want to be physically and emotionally safe. For some of our patients who that's never been anything that they understand or their context, we had a big, huge fight in the middle. It was a planned attack in Glide Health Services in our beautiful clinic that patients wouldn't even sit down in. It was too pretty at first. They couldn't believe it was for them, right? And then we got them so that they would sit down in it. Yes, this is for you. And there was a big attack that happened in there, a big fight of some guys who had been in jail, and they were in the rehab together, and they were going to jump this guy for some infraction that he had done in jail. And it traumatized our patients. It was really hard for them because they considered GHS a safe place. The fighting on the street happens, right? But it didn't happen in GHS. How many folks of you saw the movie Pursuit of Happiness with Will Smith? Okay, that's my site. That's where this work was done. Healthcare must strive for a culture of nonviolence, of learning, including patients, family, and community, all of it. So in essence, when we talk about trauma-informed care, it's really an approach, right? It's a context of how to hold the patient and how to hold the work. It's not a strategy or a method. There are certainly some premises, but it's really a way about being in relationship. If you are in relationship with your patient, I'll tell you right here and now, you can tell them anything. You can tell them anything. If you have a relationship, if they know they're for you, it may be a hard thing, they may not like it, they may get mad, but deep down in their core that they know you're for them, they'll hear it. You may have to come back. It's about that substance abuse, it's about that dirty urine, it's about that you're selling and diverting. And I know you're selling and diverting, right? They may not like it, but if you're in relationship, you can say it. If you're in relationship and you're getting ready to get that pee sample and you say, Jerry, what am I going to find in here today?
Well, we'll both find out.
Right, right. What am I going to find? Now, if Jerry says to me, well, Karen, nurse, you're going to find X, Y, and Z, then we can have a talk about it. But if Jerry tells me, oh, you're not going to find anything, and I find something, then we got a problem.
Bad urine.
Yeah. Every single reason, right? We got a rule for that too. Yeah. So a trauma-informed system is one that really is built on patient empowerment. It's by choice, collaborative, safety, and it's got trustworthiness in it. Trust on the side of the provider and trust on the side of patients. So what is it again, huh? You've been talking about this now, Karen, for an hour. Bring it home. What is it? It's leading and communicating about the transformation that this clinic, this practice is going to be changed. And you talk to that with patients. It's about engaging patients in the process. That little video that you saw about chronic pain, our patients screened it, and some of the providers thought it was too punitive. That was student work in my clinic. They thought it was too punitive, and they really didn't want the video to happen. They wanted us to change some of the language, and the patients in the pain group said, no, we want people to understand that this is a structured group, that you just can't come here and get dope and sell it. There's rules to be in this group. There's rules about how we engage, and so we let it go on. But they informed us about that. That training and clinical as well is all staff. This isn't just for doctors, nurses, and Indian chiefs, right? If you think of trauma-informed systems of care, the Department of Public Health in San Francisco is training all 9,000 of its workers. Everybody's getting trained. Philadelphia is being trained. Someone told me yesterday in the meeting that Tarpon, Florida, a very small community, 22,000 people, is becoming a trauma-informed system of care. Oregon, Portland is a trauma-informed system of care where we train everyone. Police are being trained. Creating a safe environment so people aren't judged for who they are, how they look, all of those things, whether they have a crack habit, whether they're an alcoholic, whether any of it, because we know that people come with story. We all have a story, whether we want to share our story or not. And we don't want to do a secondary trauma, the staff, right? And you also have to, I have a master's in occupational environmental health, so I care about workers. So I see our job as creating an environment that's safe for workers too, right? And that we train and hire and provide support for the workplace, that we write trauma-informed in job descriptions, that it is an expectation. So let's advance our understanding. What's the difference between trauma recovery, right, and trauma services? Trauma recovery is you're actually helping somebody to overcome the traumatic event. I sit with my psychiatrist or my therapist and we work through the event of the beauty shop and help me to reprocess that through imaging or whatever it is. We go work through the issues of child abuse and that sort of things. Trauma sensitive is I've gone to a training. I understand that it's important. I know that there's some context around this. I know that it affects chronic pain. I know that it affects diabetes, all of these other things. I get that. I've read some articles. And then what we're talking about here is TIC care. Trauma-informed care means that we actually have policies, procedures, and training, and this is how we do the work. This is our approach to each other, and it's the approach to patient care. So what it doesn't mean is that you take anything from patients, that they can act just any old kind of way, that they can cuss out the admin person, that they can act out in the waiting room, that they can threaten or scare you. That's not what we're talking about. It's not just being nicer because Jerry's had a terrible life. Oh, I feel so sorry for Jerry, right? It's not that, because actually patients don't appreciate that. They want you to be an experience. When I talk to my patients about trauma and the effects of trauma and my subjects that were in my study, they were just really happy that you asked, that you cared. The therapeutic use of self, sometimes that's what we have to get to. We always want to do something, But sometimes we just have to bear witness. We just have to hear the story. We just have to say we're sorry that it happened. And sometimes that's enough. They don't necessarily need us to fix every doggone thing for them. We like to do that. It makes us feel better, right? And then it weakens our patients because then they feel like they're powerless. So remember, trauma-informed care is about empowerment. We don't focus on the negative, all the stuff that went wrong. As a matter of fact, I hated that so much till I contacted our electronic health record folks, and I had them build a template that said strengths. So every single provider, when you had a visit, you had that big old long, what's wrong? Diabetes, crackhead, all these other, alcoholic, homeless, cancer, hypertension, asthma, all those problems that they have. Everybody knows their problems. My God, we don't need to keep listing that, do we? So let's go over here to the strengths. So I wanted everybody to have a strength. And sometimes you got to dig real deep. You know that patient, you know the one. It's like, wow, I don't see nothing, no strengths here, right? But you have to dig. And the thing that's interesting to me, it was actually really striking to me, is sometimes patients couldn't do it for themselves. They couldn't find one strength. They had been beat down so many times by family. You know what? I wish you were never born. You're just like your daddy. He wasn't worth a damn, and neither are you. You're not going to ever be anything. Wow, that's hurtful. And so you hear that script in your head, and here you are in the TL, the tenderloin, and you're homeless, and yeah, you're on heroin, and yeah, you're selling dope, and so you're fulfilling what? That prophecy. So that's our job, to help find people, find that strength for a patient and to dig into it. They might be sitting in front of you drunk. They might have just smoked some crack before they got there, but they came. And that's a strength because that's telling you something deeper. So we're going to recognize those strengths. And here on the bottom here in blue, it says people aren't just trying to be difficult. They don't just wake up and say, you know what, I'm just going to give my provider hell today. They don't do that. They don't do that. They're coping. So tick care, I think I'm recording and I'm using bad language, I'm sorry. Tick care is this little model that we came up with. It's trauma-informed, it's patient-centered, and it's culturally responsive care. This I came up with because I think it has to be really inclusive. I just really want us to say that we got to hold the patient in the center here. But we have to have primary care, substance use, we have to have mental health, wellness programs, all of those things, and they have to be supported by leadership, theoretical foundations, external resources. You know, if you're going to do a trauma-informed system of care, you got to tell your neighbors in the community what you're doing, how you're changing your focus, that you're transforming your work. Will they join you and partner with you? Policies and procedures, I stand on those. Patient advisement, you can't just sit in a room and sit around and decide that you're going to do trauma-informed care and come up with all these nice policies and not include the people that we're serving. So there's some screening tools. It's a nascent science, brand new, you know, we're just still building this work, and you know the evidence, it takes 50 years for anything to ever be accepted. We all know instinctively that is right and it makes sense, but we've got to have the literature, which I believe in literature, and the science. But this is early, so there's not a lot of studies. We don't have a lot of randomized clinical trials. Most of it's self-report, most of it's historical data. There's not very many longitudinal studies. The ANP-C study will probably be one of the first. That's been over 20 years or so looking at this work. The questions people ask are, should we do cumulative screening like we did for the folks who took the survey, where you just add up in your mind and give us a number and then talk with providers about it? Do we want people to really tell us individually what really happened? Or should we just talk about it and have a way? We don't know this, but I will say this, that screening is not really necessary. If we know that ACEs are common, we know that everybody has something. We tell everybody about hypertension. We tell everybody not to eat so much sugar, from my friend Bob Lustig's work, right? That all this sugar is not good for us. We know that washing our hands makes sense and all of this. So we should just maybe be thinking of a universal education to talk to people about trauma. It's a decision. We're still looking at it. Oregon came up with some standards. There's about 43 items on this, 5 domains: commitment by the organization, governance and leadership, so you need to have a champion, somebody who really wants to dig into this work, policy and finance. You can't do any of this without a little money, right? Because it's going to be training time and those sorts of things. Engagement and involvement. You know, the other piece of this is if you decide to do this, if you want to change your practice around this, then you also need to evaluate it. You need to look at this, because you can have a training, you can create the policies and procedures, you can go about the work, and if you don't keep your finger on the pulse, you will have drift. Just like your quality improvement around getting your hemoglobin A1Cs lower. If you don't keep looking at the data, if you don't keep making sure that there's, you know, that folks are following the protocols, you're going to have drift. There's a trauma-informed organizational capacity scale. So we want to do this, but do we have the capacity to do this? 35 items. This is something you have to pay for. My colleague at the AIR, this is their work. It's $400 for this screening, to use this tool. But it might be well worth you thinking about it. Here's the first psychometric tool that looks at staff attitudes. That's a nice barometer to see if staff are ready to are interested in this. Do they want to do this? What do they think about it? Because we do know that what happens when we're faced with our patients with chronic pain, where life is difficult for them, they can be difficult for us in the office, that there's a numbing that happens for us too. There's that distancing. Oh my God, is Mr. Brown on the schedule again? Oh geez, that's going to, how many times have you guys ever used this tactic? You tell your medical assistant, look, after I've been in there for 15 minutes, you knock on the door. See, you know what I'm talking about. You know what I'm talking about. I've been 15, 25 minutes, you knock on the door. Okay. So this will be a nice evaluation for us. I think this is really important, this whole thing about numbing, this whole thing about burnout, is to look at the professional quality of life scale. There's 30 items on this to find out where your providers are, how burned out they are in the system, right? And where the work needs, because sometimes the work needs to start there before you come to try to implement a whole nother thing. This is the ACEs screening tool. This is free, it's online. Sometimes I've told clinicians, just take the barometer for yourself and know where you are. Just like our patients get triggered, I said it earlier, we get triggered. Sometimes they trigger us. And this will give us some context for that. I like this for the quality of life scale for patients, to find out what they consider quality. What are the kinds of things that they want? To dispel this myth that they're going to be pain-free by taking a pill, right? One pill is not going to do it. But we can get a baseline here. And this, I think, is particularly important because people are resilient. Some of the folks that I've worked with throughout my career, when I go over it in my head, I think, oh my God, how are they even surviving? I don't know how they even survive, and they're surviving because of resilience. They don't recognize that as a strength necessarily. So this is a nice barometer. So the gaps are, we need a standardization of definitions. Everybody calls trauma different things. Trauma-informed systems versus trauma-sensitive systems, those kinds of things. We need some evidence-based methodologies in different settings. Most of them have been they're using it in schools, they're using it in behavioral health organizations. Not a lot of stuff really in primary care. We need some validated tools for sure, some randomized clinical trials, and as I said, a variety of settings. So this is us. I wanted to show you how we did it, and this is our work. I got 10 minutes, so I got to go. Okay. Now, click. Helper. Oh, it's going to work. First time in the history of this Irvine Leadership Award that this was awarded to nurses.
As the country moves into health reform, there simply are not going to be enough primary care doctors. What I think is so wonderful about Glide is that it's a model of using nurses as the primary care providers.
This is Trina calling from Glide Health Services. Just got you a reminder of your appointment.
Glide Health Services is a nurse-managed health center in the Tenderloin of San Francisco.
Mr. Warrior?
At our clinic, 90% of the care is rendered by advanced practice nurses.
I'm going to do your blood sugar.
Our patient population are people who have no insurance, people who are underinsured, those folks who would have no other way to receive health care services.
A lot of men, when they're not working, struggle with mood issues, including depression.
I used to be in a shelter because I doesn't have an income right now. So having come to Glide, it makes me more positive to see that they have so many people willing for outreach to you.
All low-fat diet, right?
The uniqueness of Glide Health Services is its holistic model, which places the patient in the center of our thinking.
Okay, perfect.
We provide primary care, urgent care, mental health services, recovery services, chronic disease management, and HIV prevention services. And also, we are a huge training center. We have a direct link to the advanced practice programs at the University of California. We are interdisciplinary as well. The only difference is that the nursing element is running the practice in our case.
We aren't just thinking about an illness or a diagnosis. The nurse perspective, being holistic, is taking into consideration all those other factors like where they're living, where they're sleeping, what they're eating. And I definitely want to be part of that movement.
We have to figure out ways to provide platinum service without platinum dollars. That's really the work.
In terms of cost comparison, the Glide model saves about 35% of cost.
With healthcare reform, we are hopeful that we will see this model replicated across the state of California. We feel we have much to offer.
And this is where we had a trauma-informed system of chronic pain care, really a trauma-informed system of care and services. We met patients where they were. I always think I have a big voice. Sorry about that. So in a nutshell, you get a champion, whether it's a champion for your chronic pain or a champion for your trauma-informed systems. You lobby for leadership, you align it with the mission. Context and culture matter. Community. Staff training. Create an agreed upon strategy and a plan. Don't reinvent the wheel, customize. If you need a chronic pain protocol, we stole shamelessly from Dr. Kelly Pfeiffer, and she allowed us to do that, and we customized it. Group visits are really important, they're powerful. Case conferences for support, I actually put 3 asterisks. Designate time. You can't do this without supporting people, and you have to carve that time out. Co-manage difficult cases and quality improvement and peer review. Universal precautions. Educate about trauma, diagnosis and always have a differential, patient evaluation, informed trauma consent agreements, a trial of opiates. You know, opiates were always sort of the last resort, and our patients knew that. There's a whole group of medications that can be used, a whole bunch of therapies. Multimodal. Everybody got put on an anti-inflammatory diet. We worked with our farmers markets in the area so that folks could get food. We worked with our pharmacies so people could get omega-3s and vitamin Ds and those sorts of things. Physical therapy was implemented. We used topicals, water therapy. I worked with the YMCA so people could do water therapy because they had a menu they had to choose. You just didn't come and get opiates because you had to do your part too. That was the agreement. And let's see here. Okay. This is student work again. It's supposed to be like this. Frenetic. I was the director of the Wellness Center as well.
Push it out. Don't straighten your arms, just...
These are our chronic pain patients.
Extend your energy.
So we probably won't show all of this today because I'm running over, as I always do, but it'll be on the website. You can look at it. But we had yoga, we had meditation, we had Tai Chi. All of staff could participate in those events as well. We did all kinds of stuff with patients because we believe that it's just not a Western medicine problem. We use every single tool that's available to us to get this work done. This was a volunteer, so some people say, well, we can't afford that. And I said yesterday, I'll say today, I'm the master of getting it free. I can convince people to do anything, and I know that you can too. People want to participate in community. We just have to ask and give them space to do that. So can I go to the next thing because I don't want to run over. Okay, so chronic pain considerations, consider ACEs. Substance use, these are all things that can complicate the picture for all of it because people use substance to take care of themselves. They want to numb those feelings. People smoke so that they'll feel better. They drink so that they'll feel better. Often some of this trauma causes us to be depressed and so forth. Homeless, these are all things that impact. Adaptive behaviors. We want people to keep appointments, take the prescribed medications. I don't use the word maladaptive because I think it's negative. We're going to be positive. We want folks to have adaptive behaviors, but when you see the opposites of these things, sometimes trauma flares, just like pain flares. So your psychic pain can flare. It often happens around anniversary dates, Christmas time, holidays, where people are disjointed from family are harder. Open, respective guidance and feedback, and then be really knowledgeable about self-care. And then as we transform this healthcare system, you have to earn respect and trust to get it. That's for one thing, because many of our patients have been very disrespected throughout the system, right? We want to avoid re-traumatizing, and we want to have a commitment to change. That's for us as well. Hire trauma champions, practice those, develop those in your site, look at the policies and procedures, and then consider it's really important about the vitality and well-being of the practitioners. Safety first, safety first, safety first. So if you have a patient that you are very concerned that their behavior is going to put their lives at risk, safety first. Celebrate. Discuss and mourn those challenges. You have to get support from colleagues. Use the same stress techniques that you want your patients to use. Use them for yourself, because we're all human after all. Take a vacation. The work's still going to be there. Give yourself a break, because you're going to mess up. You're not going to do this right. None of us are. We screw up sometimes, right? It's okay to admit that to our patients too. They understand that. Speak up when you need help. And then I think I'm going to end on this, mindfulness self-care practices. So it's just create a place for mental spaciousness. Sometimes during your day, take a few minutes to take those deep breaths. Take that 5 minutes to go for a walk. Sort of just achieve a sense of balance in yourself so that you can be present in the room with your patient. You can be present with your coworker, be present with the admin or the medical assistant. Moment by moment awareness of our surroundings and our bodies. They help us to cope with stress. Because I'll say it again, this work is hard and it can get very, very messy. And if we're going to survive it, we've got to figure out how to use the same strategies for ourselves. Because I said it's intertransgenerational, so you can take all that stuff home to your family. My husband said, oh, you had a hard day today, huh? Because I'm giving it all to him, right? If I don't get myself right before I get there. Thank you. It's been an honor.
Thank you. So did that work? Okay. Thank you so much, all of you. So we fine here.
I just wanted to acknowledge how radical this is. When I go meta, I'm brought back, I guess when you live long enough, things come back to the beginning. I remember Thomas Szasz in the 60s talking about the myth of mental illness, the power of language, and the iatrogenesis of the healthcare system creating the problems that they were solving. And actually, when we look above what you're saying, we're talking about iatrogenesis, the system that is broken and inadvertently has created more distress than help. And the challenge here is the one that psychotherapists face, is we have to know ourselves before we can step in and become healers. And that's a very radical concept in our current healthcare system. So this is a very exciting time, I think, and a very exciting time for mental health professionals to realize that we have a new niche, and that's helping care providers know themselves so that they can help others.
Thank you, so important. I'm going to run with the mic. I know we have 3, so maybe why don't you over back in the back there, and then if someone will put their hand up, so after we have that, okay, great. So we can flow nicely.
Yeah, I really liked your idea of a strength list, but working with EMR, you can't put anything in unless it has a diagnosis code, and all the diagnosis codes are pathology. So I'm wondering if you have any thoughts about how to modify EMR in a way where you can have
well, I'll tell you what
a strengths list.
Is we worked with our vendor, and I had them build one. Just when we got our electronic health record, we used the Centricity product, and we developed all of the stuff around recovery because it wasn't in there. We developed I should have sold this stuff to them. We developed all the stuff around care management because they weren't doing care management our style, the way we needed to do it for our patients who were homeless. They didn't have anything about recovery groups. They didn't have anything about acupuncture, Tai Chi, meditation, swim groups or anything. So we worked with our vendor. But in lieu of that, what you do is you work with your group of folks and you find a place in the chart where everybody agrees that this is where the strength list is going to be. There's some blank space in there somewheres. And so you work with them and you work with your colleagues and say, we want to do this. We're tired of just seeing what's wrong with patients. Patients are tired of seeing what's wrong with them. And it's not helpful. It's not helpful.
I thought it was so appropriate that you used a tiger, because there's actually a documentary called Paper Tigers that came out.
I know him. I know Bradford.
That if you guys haven't seen it, it's Aces
a great
in Action.
So
that's a great resource. But coming from a behavioral health perspective, what was coming up for me too when you were talking about the clients who come in and are doing great and then 3 months later start back at square one, I think the awareness is huge for us as medical professionals to be aware that pain doesn't for us equal comfort and chaos for us doesn't equal comfort, but people with these super high ACE scores, it does. And so stepping out of that pain and stepping out of the chaos is really terrifying.
Yeah.
And so not having the support to transition out of, from 0 to 18 or 0 to 25 or 0 to 60, living in pain and chaos and now not, it's super easy to revert back if you don't have the proper support.
Right.
It's so important.
Well, there's a habit loop, I think, that happens. We get into a habit of our brains get into a habit of you see a stressor, and when I have that stressor, I usually do this and it makes it feel better. And unless you really consciously step into it, recognize what the stressor is, and then make a conscious effort to do something different, you just go back to what felt good. Even though it doesn't really feel the same, you just do it because you always did it. Yeah. Kind of like healthcare. Just keep doing the same thing even though it's not working.
So first I wanted to say that I really loved your presentation.
Thank you.
I had a couple of questions, and I also wanted to share what it brought out for me. And it's not a very pretty thing, so
okay.
Please
it's okay.
hold a safe space
we're going to be
for
open
me.
and we're not going to judge.
Yes.
Yeah.
So first my question, which is that I'm not sure what advanced practice nurses are. I'm going to ask a couple. I wonder what the standard of practice and the sort of legal liability they have.
Okay.
And how that compares to being a physician, which I feel like is sort of the top legal liability, and unfortunately informs a lot of the care that I give, even though I don't want it to.
Okay.
And then the other thing that came up for me was that I spent so much time learning all this information, I felt like my job was a little bit at risk.
Oh, okay.
And at the that's the not so pretty part. But
Okay.
it comes up for me, there's like this resistance, even though like looking at your presentation, it's so clearly fantastic. Like this other part of my brain is able to really be like, wow, we totally need this.
Okay. So let me tell you a couple of things. So an advanced practice nurse, I'm a nurse, will die a nurse, born and bred a nurse, but I have additional training, right? I have 2 years of additional training that allows me to diagnose and treat with the collaboration of a physician. Mostly not for my diagnosis and treatment. Most of the standards of practice and protocols, I work under standardized procedures. You can go to the BRN website and you can look at those standardized procedures that are created in the site. You know, you work with in California, we use the term supervising physician, but there's not any standard or mandate that says that a physician has to read a note that I wrote or look over my treatment or anything like that. Most of our collegial relationship was around a furnishing of medications. So at Glide Health Services, we did not call him a medical director. We had a Harvard-trained physician who was our, what was Larry's title? He shared an office with me. He was, I can't remember his title. I want to call it clinical collaborator or supervisor. I can't remember. It'll come to me. I'm having a moment, a senior moment. And what we did there is we did peer review. And so peer review happened 4 times a year. We would pick everyone's charts, our physician colleagues' charts as well. And we had a list, and we went and we all checked it, and we would sit around and talk about the standard of care that we were providing. I will say to you that we always can feel threatened. We like to have our silos, we like to have our areas of work and all of that, but I will just challenge you to say that there's room for everybody at the table. 40 million people came into the system. Not enough docs, not enough docs, not enough nurse practitioners. We need everybody at the table. We need medical assistants, we need admin people, we need social workers, pharmacists, we need everybody who cares about the patient, because I will say to you, you don't do this work alone. And you don't want to have the burden of supervising all of it for everybody. Can't do it. It's going to kill you. It's too much. It's too much. Yeah. So there are certainly things that difficult patients in our practice where we didn't decide which provider got which patients. We didn't cherry pick them so that the doctor got all the real sick people. We didn't do that, right? What we did was, if there was a patient that was difficult and we needed support, then we would co-manage the patient. We would co-manage it so that it brought my level up. Right? There were times that he would come to me or come to us and say, gee, I'm having this real problem around this patient. Let's talk about this. Because he was great with the biology and all of that stuff. But that other context he often didn't have, the other approach. He's now the senior editor for PLOS PLOS magazine. He left after the clinic transitioned. He left, and we left now. So I'm hoping that that answers your question. There's no, and you know, this doesn't just happen with physicians and nurses in advanced practice, nurses or PAs. So here's the nurses standing, I don't want that nurse doing such and such. I don't want the medical assistant doing stuff. I don't want to do it, but I don't want them to do it either. So, you know.
Thank you, Karen. So we're at our bottom of the, let's see, the half hour or whatever. We're going to start our lunch. I want to encourage people, as you are eating your food, really take your food in. Eating mindfully is one of the great gifts of mindfulness that I've been able to enjoy. So really taste that food. Maybe chew it a little bit more than you usually do. Enjoy your colleagues, and we'll meet again, let's see, I think it's 1 o'clock, is that right? 12 o'clock.